Hey guys, welcome back to the Lube Tube. We're here for episode 4. What in the hell is going on with me? Perimenopause, the good, the bad, and the really ugly. It's myself, Jeanette Nashke, and my co-host, Brittany.
Hello.
All right, so perimenopause. This is a rough one. This is one that actually a lot of women have been asking for. And I'm actually really excited to talk about this because I think this is a topic that is starting to make its name in social media, and people are starting to talk about it more. And so I think this is a perfect time for us to chat about what kind of happens to our body as we go through this process. I can't tell you the amount of times that women come to me that they maybe have brought this up to another provider or maybe a primary care, and they've been given antidepressants because if you are going to go through it, which we all do, or if you've been through it, you might remember that at that point in your life, you felt like your body was basically turning on you and symptoms that you've never had before, they were starting to rise up.
So perimenopause, just so we can start off on everyone on the same page. Perimenopause essentially just means the time around menopause, before menopause, and when your body's kind of just making that natural transition to menopause.
Yeah. And it's basically where all the hormones that you normally had before, which in females is going to be estrogen, progesterone, and testosterone. Yes, that's one of our hormones too. They just start to go down. And then guess what? They go back up again and then they go down. And so there's this erratic behavior of these hormones where before it followed your normal cyclic behavior where just like you would have in a month for a period, they go up and then they come back down. Where perimenopause, there is no rhyme or reason to it. And it can make us feel really off, like really off. So that's kind of what the whole point of this is today, is talk about what those symptoms are, how we can detect those symptoms and what those symptoms mean, and then try to get you a plan on how to talk to your provider about it and getting you some help with that. So I always wonder, like, why is this overlooked, right? Why do people get put on antidepressants? Why do people get told, oh, this is just normal, natural part of life. You know, this is just how it's supposed to be. I think a lot of times it's misdiagnosed. I mean, especially considering that perimenopause in some women can start happening at the age of 35, right? 35 is pretty young. So when you take the average age of menopause, menopause is the complete stop of all the hormones, where perimenopause is the getting to the complete stop, where the estrogen and those other hormones that I mentioned before are starting to go down, but they're not all the way down. So perimenopause usually happens 10 years before menopause. So women usually have different times that they go through menopause. Yes, the average age is 51, but there's some women that have menopause at 45. So that means that those perimenopausal symptoms can start at 35, right? So it's usually about 10 years prior to menopause.
Isn't there also, there's some sort of like algorithm of sorts where if you started your period at this age, you can expect things to begin at this age. It's not a perfect science, obviously.
Right.
But I know I've heard that many times that you can expect XYZ.
Sure. Like if a woman starts her period really young, there's a good chance she's going to go through menopause really young, right? Or the vice versa. If she starts later on in life, she might have a period all the way through, mid 50s. I have some women that are still getting a period off birth control when they're 50, 53, 54 years old. So I think that even though they're still getting monthly or maybe every 2-month periods, I think it's important to understand that doesn't mean they can't have these perimenopausal symptoms. I think a lot of times women think, oh, I'm still getting a period every month, then that means I won't have these symptoms. Well, that's really untrue, actually. I have so many women that come to me that say, well, I'm still getting a period every month, so I can't be perimenopausal. Well, just because you bleed every month doesn't mean your hormones aren't what they were 5 years ago.
Right.
When I look at, my group of friends, we're all in our, late 30s, early 40s, mid 40s. So most of my friends that I hang out with are going through this right now. And maybe they just don't realize it because they're thinking it's something else. So that's what I think this whole goal of this episode is, right? To open eyes, right? To tell you, hey, look, this is this is what it is. You're not going crazy, right? You're not losing your mind. It's truly that lack or losing of hormones.
I feel like you're talking directly to me right now as you're looking at me in my eyes. As I told you when we were walking in, that I felt like I had hot flashes this weekend.
You know what? You probably did have hot flashes, and you probably just thought the air conditioning wasn't working.
Low key, or maybe high key. That was exactly what I was thinking. So please stop looking at me. So just stop.
Hey, I mean, this is the thing. Like, a lot of our most common symptoms, we talked about this last episode, first initial symptoms are going to be where you have vaginal dryness, right? And you go your whole life without knowing or noticing your vagina. And then one day you're like, whoa, my vagina, right? Mm-hmm. But there's other symptoms, right? There's going to be the hot flashes like you just had this weekend, right?
Okay, I told you to stop.
Okay, yeah. Well, I'm just saying.
No, I'm supportive of you talking about this. Keep going.
Yes. And then there's, night sweats, there's irritability, there's brain fog, there's low libido, there's joint pain, there's decreased energy levels. There's where before on the weekends you would look forward to going out and doing a bunch of things with your family, but now you just don't have that energy left in you. That's funny because a lot of these symptoms are actually symptoms of depression. And if you look it up in a textbook. So, that's what I think is important, is that you can have these tools that we're going to talk about today, and you can take them to your medical provider and be like, hey, I'm having all of these and I'm not depressed. I think it's something else.
Yeah.
Right?
Let's talk real quick. What exactly is happening in the body?
Every month when we are pre-menopause, we are having fluctuations of that estrogen and progesterone. And estrogen is being produced and released by the ovary, right? And there is a little stimulation that comes down from the brain. It's actually in one of the glands in the brain. And it sends down a stimulation called follicle stimulating hormone, FSH, okay? This FSH then hits the ovary and it stimulates the ovary to make or produce estrogen. With that, when the estrogen is produced, it sends back that feedback to the brain and says, hey, we've got plenty. You don't need to send any more FSH or follicle stimulating hormone down to me. So when that's all working perfectly, the FSH is going to be low because it doesn't need a lot of stimulation, and the estrogen is going to be in normal limits, right? So it's a constant feedback. Well, when the ovaries stop or get tired or they're not producing as much estrogen, the FSH is going to go up because the body sees that there's not enough estrogen there for it to produce enough for the body to have its normal cycle. So then what the body says is, oh, I need to send down more stimulation. So the brain just sends down this massive amount of follicle stimulating hormone. So when they're not producing like they used to, there's not as much estrogen, which therefore causes some of our symptoms. So then if you were to look at blood work, your FSH, follicle stimulating hormone, would be really, really high, the estrogen really down, okay? So when that all happens, these fluctuations can cause all kinds of symptoms, right?
So when we are talking about these hormone changes, what are the changes that we're seeing on the body?
Yeah, so I don't think people realize that how many estrogen receptors there are in the body. There are estrogen receptors everywhere: brain, joints, bone, muscle, gut. I mean, they're literally everywhere. So what can happen is that when that estrogen goes down, we start becoming symptomatic, right? There's going to be physical symptoms. There's going to be emotional symptoms. And so the problem there is that what do these symptoms look like? They're going to be different for every woman, right? There's going to be some women that have just joint pain. There's going to be some women that have just hot flashes, just night sweats. And that's where it takes you and your provider having a really good conversation about your symptoms to see what your body needs.
And I think it is good to note that there are some people that will have very few symptoms and some super blessed people that are like, what are you talking about?
Right. It's crazy because every time I see a woman who is in this age range, I ask them if they're having any of these symptoms. And there are some women that don't have a single perimenopause or menopausal symptom. And you're right. Those those women are blessed because then I have other women that these poor things are just totally affected by it. There's all kinds of symptoms that obviously we kind of mentioned just a minute ago, but there's the big one is menstrual irregularities, right? So where you were having a period maybe once a month, now you're having a period maybe every 6 weeks, every 8 weeks. Maybe you're having 2 periods in a month. Maybe you're having 3 periods in a month and your bleeding is all over the place. This can be very normal of what we call perimenopausal bleeding because of that fluctuation of hormone, right? Oh, then there's the good old hot flashes, right? You want to talk about this one?
Okay. Here we go again. Here we go.
Okay. So hot flashes, they will basically be where you're feeling totally normal as far as how you feel, as far as heat or your body temperature. And then all of a sudden you'll just break out into a clammy sweat, right? The back of your neck starts getting sweaty. Maybe you have to pull your hair up in a ponytail just because you cannot handle the temperature that you're at right now, even if you could be in a totally normal cooled room at your normal AC temp. These are not have to be every day. They can be kind of all over the place. They can happen every day, obviously, but depending on the patient, they might get them just very, very seldom. And that's that drop in that estrogen that your body is sensing. Then there's the night sweats, right? Night sweats are different than hot flashes. So night sweats are where you wake up in the middle of the night and your nightgown is drenched, right? Or maybe the back of your neck is sweaty, or you find yourself having to kick the covers off in the middle of the night, even though it's nice and cool in your bedroom. These are more driven by the lack of testosterone, actually, than the estrogen. So your treatment would be a little bit more tailored to getting that testosterone up rather than the estrogen, okay? Mood swings. Oh, this is a fun one, right? I know personally, this is my big symptom. I have this basically emotional fluctuation that I was having a really hard time trying to figure out because if you know me personally, I've been through a pretty traumatic thing in my life. And so a lot of times that will rear its ugly head and kind of show in forms of anxiety or maybe some depression. But I was starting to feel this feeling more often. And like we talked about last time, brought it up to my therapist. And she actually is the one that's like, Jeanette, you talk to people about this all day long. Do you think maybe this is more of a perimenopausal symptom, right? Because I was finding myself not sleeping well at night, having these bouts of anxiety for no reason, having a really short fuse with my husband and my kids, which there was no real reason for that. They weren't doing anything different. Life wasn't any more stressful than it usually was. And I needed to figure that out. And so that we did some blood work, and obviously you're the one that helped me out with that. And now I'm doing some hormone replacement therapy that has really helped with that. So, it might not be that you're just becoming this anxious, crazy mess because you're now going through anxiety and depression. No, it could absolutely be that these hormones are just wreaking havoc on your emotional stability. So I think that's an important thing to look at, right? Because so many women could be dealing with this exact symptom. Do you have a lot of women at the hormone clinic that you see that this is one of their big symptoms?
Yes. And it's certainly, it's actually wild how many patients that I have that will get off of their antidepressants or will get off of their anti-anxiety medications after they've been on the hormone replacement.
Right? Like I have seen that too. And we're going to talk a little bit later how we can actually use antidepressants if we don't want to use hormones. But yeah, I've absolutely seen that where once you get those hormones optimized, they don't even need the antidepressant anymore. And trust me, there's a lot of women that are on them. And I think they have an absolute place for sure. I prescribe them all day long, but I like to make sure that there's nothing else I can do for them rather than giving them an antidepressant, which has its own list of side effects.
Right, definitely.
We talked about this a little bit earlier, but the sleep disruption, that's another thing that women will come to me and they're really having issues where maybe they can't fall asleep or maybe they can't stay asleep. They're waking up multiple times at night and are just having that sleep disturbance that's not allowing them to get to that REM, right? Where they really rest and just basically refocus the mind. That's a lot of times progesterone, right? So progesterone is going to be that sleep hormone, right? That helps us sleep. Testosterone helps with that too. So a lot of times if we can manage those hormones, people are reporting that maybe their energy level gets better because they're obviously getting that better sleep. I know personally when my hormones are not where they should be, I do not sleep as well as I should. I find myself falling asleep okay, but not staying asleep. It's just really erratic sleep.
Right. Yeah. And I also think these last few things I see every day, and that's going to be the fatigue, the weight gain. Weight gain's a big one, especially in, you have to remind me what we call it.
Central body fat.
Thank you.
Yes.
I was going to say abdominal, but forgive me. And then the libido, obviously, brain fog, and as always, our vaginal dryness. Like those I see, I think almost every patient.
For sure.
It's those, the fatigue too. I mean, fatigue's a big one.
The weight gain, right? So frustrating because these women are a lot of times working out harder than they did when they were in their 20s and early 30s. These women are spending hours trying to get their body back to where it was. They are eating cleaner than maybe they've ever eaten in their life and passing up on that junk food and passing up on that extra glass of wine, right? They're doing what they're supposed to do and they're still gaining the weight. And a lot of times as a provider, this is really frustrating too, because you're trying to find that magic for them. And when they're already doing all of the right things, it's really frustrating because you want to find that trick for them. Let's talk about other things that can happen as far as the hormone changing. What can happen at like the cellular level and kind of what's happening there that maybe we don't feel or see, but that we could actually find as a medical provider. We've noticed that we just talked about like the fat buildup, right? So when the estrogen falls, the fat can also build up in the arteries, which then narrows them, increasing the risk of heart attack, stroke, and coronary artery disease. There's studies that show that the sooner you start estrogen replacement in these perimenopausal females actually lowers the risk of cardiovascular events. It does not increase the risk. Cholesterol levels. So you might go your whole life and have a normal, what we call lipid panel, which is going to be your total cholesterol, your LDL. Think of LDL as the loser. So it's your bad cholesterol. And then the HDL, which is your hero. It's your good cholesterol. And then the triglycerides, right? You might go your whole life with normal levels. But as we reach this perimenopausal phase, you might get your lipids checked as your annual blood work, and they're now kind of off, right? Your HDL is now low, your LDL is high, which is the exact opposite of what you want. And you have a total cholesterol that's higher than it's ever been. This is also could be a product of not just bad eating or genetics, but also the hormonal fluctuation.
Can I just do a little PSA about cholesterol?
Yes.
Because I feel like this is not talked about enough. You can have the best diet and still have terrible cholesterol.
It's so frustrating.
And you can thank your parents for that. Or you can just have no explanation for that.
Absolutely.
Right? I feel like I get people that reach out and say, here are my labs. What am I doing wrong? And I have the perfect diet. I'm exercising and my cholesterol still sucks.
Right.
Well, I don't have a good answer for you.
Right.
I really don't. So I know there's a lot of people that can really harp on these lab values that are not where they want them to be, but sometimes there are things that are just out of your control.
Right.
So
absolutely. Especially like you mentioned, the genetic proponent to it, right? Gosh, there's people that have what we call familial hyperlipidemia, just a really big word that I got it from my mama, right? So it just means that, your body is meant to have high cholesterol. Does that mean that we can't fix that? Well, not necessarily. We could absolutely put you on medications that help lower cholesterol. A lot of people are adverse to that. But there are obviously some really great meds out there, and that's a provider and patient conversation for you to have. But, if you're already doing everything you possibly can and you're still not where you're at good levels, then maybe that is a conversation you should have, right? So something to consider. Blood pressure. right? Blood pressure is another one of those things. You could go your whole life and have normal blood pressure your whole life and everything is fine. And then boom, your blood pressure can start going up. And this is one of those things that you might not feel. Blood pressure or high blood pressure, also known as hypertension, is silent and it can be very frustrating. And a lot of times it's not symptomatic until it's really high. And those symptoms are usually like headaches, right?
Mm.
Maybe a little bit of chest pressure, just feeling kind of fatigued and tired. So definitely recommend seeing your provider for an annual visit, like we mentioned in that other episode, and just getting all those vitals checked, right? And making sure everything is okay there. Then there's also the increased risk of blood clotting. This is a touchy subject, right? Because if we're talking about hormones and blood clots and what causes that and what doesn't cause that. But, as we age anyways, there's an increased risk of blood clotting. And so, this is something that I absolutely think is patient dependent and their personal risk and maybe what they have as far as their past medical history that does also put them at increased risk. So I think that when we talk about this, we're talking about the fat buildup, the cholesterol, the blood pressure, the blood clotting. And then also, as far as like we talked about the body fat distribution, Brittany mentioned the central body fat. And this is the most frustrating for all women because that's the part where everybody wants the flat stomach and they want the figure. And as we start to get older, that figure starts to change, right? And where we used to put our fat maybe on our booty or maybe in our thighs, it's not just there anymore. It's now in the central part. And that can be obviously very frustrating for a lot of women. So this comes down to hormonal optimization. This comes down to making sure that you're eating correctly as far as low carbohydrates, high protein, getting enough soluble fiber in your diet, omega-3s, a lot of really great things that we can help kind of optimize for you to try to get that better for you so that central obesity doesn't drive you nuts, right? The next one is the different ways to manage this, right? So, there are non-hormonal and hormonal options, and we're going to kind of dig into both of those. The non-hormonal is basically doing a little bit more of a natural way, right? So diet, nutrition. So, maybe adding on foods that can support more of a hormonal balance. Like we mentioned, the fiber-rich foods, soy foods, getting enough of the healthy fats, the omega-3s, calcium, vitamin D, and what we talked about before with the fiber, what that does is it lowers your insulin resistance, right? So if you have enough soluble fiber in your diet, there's an increase of the ability to basically lower that insulin resistance. Well, what does that mean, insulin resistance? Well, we all release insulin from our pancreas if we don't have diabetes in a natural and normal way, where if we eat something, the insulin is then released, which then pushes that sugar into the cell. Well, if the body is resistant to that insulin, what happens is it's not using that insulin appropriately. And if the insulin is not being used appropriately, that means that that sugar is not being pushed into that cell, which then is being stored in a different way. Well, then when it's being stored and we become insulin resistant, our body creates more insulin because it says, well, if the sugar is high and we're not using it appropriately, maybe I need to make more insulin. So the body then makes more insulin. And then what happens is we start to gain weight. So by making better life choices as far as diet and exercise goes, we can lower that insulin resistance. That way we're actually metabolizing that sugar or that carbohydrate appropriately and not causing it to cause central obesity.
Well, and then the exercise piece is important, I think, both for physical reasons, obviously, but also for the mind. I don't think that exercise is a huge topic.
Why are you staring at me? Because I didn't go to the gym? Right. Let me say, don't go to the gym. Is that what you're saying?
This is called payback.
Oh,
this is what this is.
Okay, God. I had a patient, and I'm not going to say your name, but I hope you're listening, that every day she would say, did you go to the gym today? Did you go to the gym today? You need to go to the gym today. And she said, one day you're going to reach 50 and you're going to be real pissed off that you didn't go to gym every day.
Listen, I think it's important on so many levels, but what it does for your mental health,
right?
You can't even put a value on that.
Sure.
And I think the older we get, the more mature we get, I should say,
Okay.
the more important that becomes, especially when we're talking about hormones that just may not be
Pumping.
pump the jam, pump it up.
Do you know the words? Well, your beat is pumping and the jam is get your butt. Okay. All right. So
nope. I guess I missed that song.
No, you didn't. It goes, oh, it's really on the bus tonight. Make my day. See, you do know that song.
I do remember it. But like that was that. Why do we know that song?
Because that was a jock jam.
Oh, jock jam. Oh my God.
Taking it back to the jock jams.
Oh, Jesus.
You know you had that CD.
I probably do. No, I just remember like.
Do you still have it?
Well, I have all my CDs still in a binder. Like, what am I going to do with my CDs? I don't know. But do you remember how they used to have, oh God, it was like now too. Oh. And like now yes. You're reminded of how old you are when it's like now 232.
Yes,
like,
exactly.
Oh God. Like, why are we still doing now? I don't know.
Well, you know, it's really funny. This is a total sidebar, but one of my good friends, Casey, she was going through some stuff and she found all of her burned CDs, like that she burned from like 1995 and on. And these songs that are on there are freaking hilarious because those were our jams, right? And she's trying to get her kids into it, and it's not
happening. No, uninterested, Mom. Uninterested. Okay, back at it. Sorry. So, and I guess with the exercise thing, we also want to talk about managing our stress, and a lot of people can do it with meditation. I'm terrible at meditation. I want to be better.
Yeah,
I want to be better.
Never been good at it.
I mean, when they tell me to breathe in and out, I do, but like, am I doing it right?
Are you breathing right?
I don't know. It's just I want to be mindful.
Okay, so
I want to be cutesy.
Oh, demure.
Yes, I want to be all of those things. I just need to be better.
Okay, I've never been able to meditate, but I actually
the people that can
are good at it.
Yeah, and they speak.
Yes.
I can't even talk.
They love it.
Yes.
And they always recommend it. And I've tried it and I can't ever get there. I can't get there.
Our point is that if you can meditate,
teach us.
Yes, teach us. And if you can't, we're with you and we're going to learn.
Yeah.
Be patient with yourself.
You're going to learn today.
Yes, we are going to learn. Okay. And this last one.
Oh, sleep.
Sleep hygiene. How many people suck at this?
Oh, yeah. You know, I suck.
Well, it's mostly, I don't want to say mostly, but our phone is a huge issue.
Oh, yeah.
Right? Screen time, huge issue. And I'm guilty of it.
Yeah, I think most of us are, right? I don't know very many people that can put that phone down an hour before they want to go to sleep and not look at it.
I don't even have social media.
I know.
And I still have that problem.
Social Brittany. I don't understand how you're so sociable and you love hanging out with people, but you don't have social media.
It was not serving me. And when something's not serving me, effing O's. Get out of here. So I'm totally okay with that. So
oh man.
Okay, why don't we move on to the medical treatment of this? How do we treat this?
So that is basically considering hormones, right? So hormone replacement therapy, or short HRT, right? This is what Brittany does. This is her bread and butter. And this is where she helps so many women so many days out of the week. So basically what this is giving back the hormones that we're no longer making or we're making less of. What do those include? Those are the top three, right? Estrogen, progesterone, testosterone. And I think there's some education that needs to happen here, right? That's probably a big piece of education that needs to be happening here. Estradiol is basically estrogen, and progesterone, they have to be given together if a woman still has their uterus. Okay. So if you have not had a hysterectomy, you cannot be on estrogen alone as far as being postmenopausal, right? If you're perimenopausal, right? Meaning you're still getting a period, you're still producing estrogen and you're still producing progesterone, but at a lower amount, that needs to be really considered with your provider, okay? Because you still need that protective mechanism of the progesterone. So what progesterone does is it protects that inner lining of the uterus, right? If I was to give you estrogen alone and you were postmenopausal and you did not have progesterone, that lining would thicken and thicken and thicken, just like it does when we're about to have a period. The problem is that lining, as it thickens, the cells can change, right? And that can cause those cells to change into what we all don't want, which is cancer cells. So how do we fix that? We give progesterone, because progesterone is going to thin that lining and make it so you don't A, have another period, right? Or B, have those cells change to something like cancer cells, okay? So there's ways that we can do this if you're still having periods or if you're perimenopausal. There are progesterone-only birth controls. My favorite on the market right now is a brand name called Slind. Slind is a really good progesterone that has low side effect profile that you don't have to take every single day at the same time, like a lot of the mini pills or progesterone-only pills. And that will protect that inner lining. The other way to do it is like a progesterone-containing IUD. So like a Mirena, a Kylena, a Liletta, a Skyla. Those are all IUDs that go inside the uterus that protect the lining.
Those are fun names,
right? So
That's cute.
Sidebar, there was a lady that got pregnant on a IUD.
Mm-hmm.
And then
which can happen.
Yes. And so she named her baby Kylena.
No. Stop.
I mean, I thought it was genius.
I mean, that's genius.
It's a really cute name too.
So cutesy. Oh. Yes.
Oh, but anyways, so those progesterone containing IUDs, what I like about them is that they are basically localized hormone, right? So they're going to protect that lining. And then plus you could do estrogen on top of that, that can protect from all those side effects or those symptoms that you're having of perimenopause. So I think a question that you need to have with your provider is, A, are you on a birth control containing estrogen? So are you taking a birth control that has estrogen in it? So a combination pill would be like a low estrin maybe, or a low estrin, or, or is it the Nexplanon, or sorry, excuse me, the NuvaRing, which is a ring that you place inside the vagina. Those are all estrogen and progesterone containing birth controls. There are some women that are on those pills or rings and they're still having perimenopausal symptoms, right? So in that case, we really just need to decide, hey, would it be better for this patient to get off the estrogen containing, maybe do a progesterone only and add on an estrogen product like a patch or a cream or a pellet that might be a little bit more beneficial for them as far as helping those symptoms. There are recommendations as far as a lady being on a combination pill or a combination birth control too long. Personally, I don't like for my patients to be over 45 taking a estrogen-containing oral birth control. I prefer more after 45 and up. We recommend other birth controls, which would be, like the progesterone onlys that I just mentioned, and then adding on an estrogen component. So, the risks and benefits are going to be different per patient. As far as oral estrogen, I'm not a huge fan because it does increase the cardiovascular risk. So I tend to stick more with like the transdermal approach, which is going to be the estradiol patch, adding on a estradiol cream that you apply daily, or even a estradiol pellet like you do every day.
Mm-hmm. And then we've talked about estradiol, progesterone, but another big one, obviously, is the testosterone.
Mm-hmm.
And I know that I get a lot of people that come in, and when I tell them, hey, this is where your labs are, they're like, what?
Yeah. Let's talk about that.
Yeah.
I think the first time you drew my blood work, I was probably 38. Yeah. Maybe 37. 37. Yeah. 37 years old. My testosterone, it was 0. Remember? Mm-hmm. It was literally less than 12. The lab couldn't pick it up. And this is one of those things that it opened my eyes because I literally thought I was just tired because I have 2 boys. We go a million miles an hour and I've got a full-time job trying to raise the kids and have a job and, be a good wife and be present. Right. And I was burning it at both ends. Maybe I'm just exhausted. And then I saw my blood work and I was like, whoa, my testosterone is 0. And you were like, Jeanette, you could totally feel so much better. You're like, yeah, you go 100 miles an hour, but maybe we should try some testosterone replacement, right?
Right.
So I personally went with the BioT pellet. You don't have to do the pellet. That's not, the only option available. There are testosterone creams. There are sublingual tablets. There are injectables. I'm not a huge fan of the injection of testosterone because it's actually based in an oil, which has its own side effects and risks. So I tend to go more so with the pellet, the cream, or a sublingual tablet. Insurance doesn't cover any of that for women, testosterone replacement, and which I think is bullshit, if you want my honest opinion.
Yeah.
It's complete bullshit. They will cover the estrogen and progesterone if it's done through, a prescription, but they're not going to cover that testosterone.
Because this is a man's hormone.
Oh, yeah, that's right.
Wrong.
That's right. Yeah, exactly.
That's wrong. And for all our men listening, you also produce estrogen.
That's right. So, just so you know.
Yeah. So we need to stop saying, oh, that is primarily for men. That's primarily for... No, we need... Both men need estrogen. We need testosterone. Like right. There are means for both of those. So
right. And I think it's important that, they're at totally different levels, right? A man's testosterone is going to be 10 times what ours is, right? But at the same time, when we don't have this testosterone, we have these symptoms that we've already mentioned. I remember after you placed my first pellet, within a week, I was sleeping soundly. I was not having those night sweats anymore. My energy level was up. For the first time, and I can't tell you how long, and this is going to get maybe a little bit TMI, I was thinking about sex again. I mean, our lives are so busy. The last thing I was thinking about was having sex with my husband. And no offense, Daryl, I love you, but damn, our lives are crazy. But since the pellet or since adding on testosterone, it has made a huge difference in my life.
This will definitely turn into another episode for us because there's a lot to be talked about. Mm-hmm. So I think we'll leave it at that, okay. But we'll definitely return at some point. But let's talk about the non-hormonal.
Yeah, because let's talk about the women that can't do hormones, right? So women that have maybe have a personal history of some type of estrogen, progesterone, or testosterone, not so much testosterone, but progesterone or estrogen hormonal cancer, right? Like a breast cancer. Those women I absolutely would not recommend hormones for. There are some providers that give these women hormones, but that's not me personally. So there are some good options. There's, like we mentioned before, a good company called Bonafide. Bonafide is an entire company that doesn't have any type of hormone in their product, that is all natural, that help with, they have a couple products that help with the libido, one that helps with vasomotor symptoms, which is our hot flashes, night sweats. And then they have the vaginal dryness, like we mentioned earlier. So that's a good product and a good company to look into. I do recommend those all day long. They also have another product called Serenol that I'm taking actually that helps with the mood swings like we talked about before. I've had a lot of really great results with that product. So I do recommend that company. And then back to the antidepressants. Remember, we talked about this earlier. Vasomotor symptoms, which are the hot flashes, like we were talking about, the night sweats, the irritability. A lot of times if somebody cannot take hormones, you can actually prescribe them what we call an SNRI. Okay, a very common one used for this is called Effexor. Effexor is used, or the generic is called venlafaxine. This is used a lot of times to help with those symptoms, and it's very commonly prescribed. As far as natural products, there's evening primrose oil, there's black cohosh. These are all things that you can find in more of the natural product aisle at your grocery store or your drugstore. And then another one that I highly recommend, honestly, for every perimenopausal female is magnesium glycinate. There's a lot of magnesium on the market. I mean, there's all kinds of magnesium that help with constipation, magnesium that help with leg cramps, but magnesium glycinate specifically is the one I recommend for perimenopausal/menopausal females.
I know. I need to get it. I get it.
I could have told you that a couple of times, but
I know.
Okay.
It's okay. So we touched on how this can affect mental health. So we know that just overall mood, there's the risk for anxiety, depression, increased risk, I should say. Mm-hmm. And then also, we haven't really talked about this, but as women with this...
social media?
Yes.
Okay.
Yes. Here we go. This is why I'm not on social media.
I hear you.
The body image.
Yeah.
Body image becomes a big Absolutely. Issue. I mean, if it hasn't already been an issue, right? With aging.
I know.
Let's talk about how celebrities can kind of really wreak havoc on you. Like Jennifer Lopez. How old is Jennifer Lopez?
I don't know. But why does she look so damn good?
She's in her 50s. I'm pretty sure,
and I
like
think it's
early
a Jennifer
50s.
thing, like Jennifer Aniston.
Oh my gosh,
Ooh,
I know. So all of these
smoking.
ladies that are still looking phenomenal.
Yeah.
We need to be reminded that they have unlimited resources.
You're right.
Unlimited resources. Speaking of Paris Hilton.
Yeah.
Okay.
Okay.
She's not in her 50s, but I think she's in her 40s.
Mm-hmm.
She went, I don't remember what I was watching. Maybe I was on BuzzFeed. I don't remember. But she has like a complete spa in her house with everything you would ever want to halt aging.
Holy smokes.
Yes, like anything and everything.
So we can't compare?
That's what I'm saying, right? It's very easy to have these comparisons with these people that have the unlimited resources.
Yeah.
But we're working with what we have.
So we need to just embrace the suck.
Yeah.
Okay.
Absolutely.
Embrace the suck.
Yeah.
Right. And know that it sucks, but there's options. And like I tell my ladies all day long, this is normal, but we don't have to deal with the normal, right? We can fix this so it's not your normal. So maintaining that healthy routine, trying to balance that life, just like you're balancing these hormones, we got to balance the life. So, I think the big thing is consulting with your provider. What does that look like? There's some labs that I would ask for. It's going to be that FSH, remember that follicle stimulating hormone. If you're on a birth control containing estrogen, like the low estrin or the NuvaRing or a different type of birth control, it's going to make that FSH, actually, it's going to throw that off. So you need to make sure that you talk to your provider about that. You might want to take a hiatus from the birth control for a little bit to see what your actual FSH looks like. I know for some women, I have them stop it for about 4 to 6 weeks, and then I repeat their FSH after being off of it to see what they truly are, because I can't tell you how many women are on a birth control and they're actually menopause. They're in menopause. So why do you need the birth control anymore? Let's stop the birth control because that's just putting you at cardiovascular risk. Let's put you on an estrogen patch or put you on a pellet that contains estrogen and then give you that progesterone at night to help you sleep. So you might need to chat with it. If you're 48, 50 and you're still on a birth control, maybe you need to have that talk, right? And then also the FSH, like we mentioned, the estradiol, which is another lab you should get drawn, and the testosterone, right? Another good one that I know you commonly draw is something called a sex hormone binding globulin. And that can be really helpful to kind of look at that testosterone to see how much of that testosterone you're actually getting and how much you're actually feeling. And let them help you navigate it, right? Because there's lots of options, like we mentioned here, for treatment. And though they're not the same for every patient, but there are a lot of women that can benefit from all of this.
Yeah. And so I think the last thing we kind of need to touch on is some questions that we get all the time.
Yeah.
All the time. So during perimenopause, can I get pregnant?
Ooh. Yeah. The answer is yes. There's a lower risk of you getting pregnant just because you're probably not ovulating like we were before in our 20s where we're, releasing those eggs. But yeah, you could absolutely get pregnant. If you're still releasing eggs with ovulation, yeah, you could still get pregnant. So that's why I think getting that lab done off of a birth control is important, because if you're still having a low FSH, then that tells me that there is a chance of you getting pregnant. So that's where I would add in that progesterone only birth control, like the IUD or the pill, and adding on the estradiol patch or the pellet or the cream, because that would actually help you with all these symptoms, plus keep you from getting pregnant.
Okay. Also, how long does this last?
That's such a pain in the ass question, right? Because it's like, I don't know. Some women, this can last a year, some women 6 months, some women 5 to 10 years, right? Like we said, menopause or perimenopause can be 10 years before menopause. Right? So it could last 10 years.
Yikes.
Yeah. So there's that.
Okay. And this is a big one. What's the difference between what I'm feeling right now and what menopause is going to be?
Yeah.
Loaded question.
Loaded question.
And I don't know if there's a clean and cut in.
There's really not.
No.
But we can make that transition so much easier, right? That transition can be so much easier rather than going from perimenopausal straight to menopause. And so that's the losing of hormones to the lack of hormones. And if we can make that transition easier with adding on these hormone replacement therapy or the non-hormonal stuff that we mentioned earlier, then that's my whole goal, right? There's a lot, and this is, like you said, this is a big topic that we're going to dive into as well, as far as in the next episode coming up about this perimenopausal, menopausal stuff. But, just making this transition easier for you and for me, making it easier for my patients is my whole goal, right? So it's a great question. It's different for every person.
Yep.
So closing, like talking about this, let's talk about the recap, right? What you're feeling is normal. Doesn't mean we have to deal with the normal. Symptoms could be the hot flashes, the night sweats, the irritability, the brain fog, the muscle aches, the joint pain, the decreased libido. Gosh, there's so much that it could be. And there's treatments available. You just have to come see us, right? There's labs that we can do. There are options that we can do moving forward, non-hormonal versus hormonal, lifestyle adjustments, vitamins, exercise. As far as mood things, we talked about, mindfulness and meditating, which we're going to learn how to do, right?
Yep.
Okay.
It's definitely.
Yeah.
Breathe in.
Breathe out. So yeah, I hope that you learned something from this. I hope they did. You think people did?
Yeah. If not, there's lots of TikToks that apparently, I don't know. That's what I've heard. I've heard that it's all over TikTok. And so we needed to talk about it.
Oh, can we not talk about our TikTok? How terrible it is. I'm going to need you to make some TikToks.
Okay. How about I'll take over the TikTok?
Okay. All yours. Have it.
I'll take
Run
over
away.
the TikTok.
Okay.
Is it called the TikTok or is it just called TikTok?
I think it's TikTok.
Anyway, I'm officially taking it over right
It's
now.
all yours.
Right now.
Y'all get ready. It's about to be good.
Real quick, I think everybody should know that our next episode is another hot topic that we keep getting questions about.
Mm-hmm.
And it is something called PCOS.
PCOS, polycystic ovarian syndrome. This is a very frustrating thing for very many women. And I think it's also an underdiagnosed thing. I think now that things like social media, TikTok, different podcasts out there also, they're talking about it. And so I'm getting so many young girls coming in and asking if they have it. And I love that because it can affect their lives tremendously in different ways. And we're going to talk about that next time. Anyways, ladies, thank you. And gentlemen, if you're listening, thank you so much for just listening to us today.
All right. We'll talk to you soon.
Bye. The information provided in this podcast is for general informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition. There is no provider-patient relationship formed. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. The hosts, guests, and producers of the podcast do not assume any liability for the application of the information discussed. Reliance on any information provided by this podcast is solely at your own risk.